Good afternoon. Thank you very much, Choon, for your kind words of introduction, and good afternoon to all of you colleagues out there. Hear that there is a good turnout today. I'm very glad to see so many today on the Saturday afternoon. We're going to look at what is new in the revised guidelines for depression, and looking at the old one, which is 2004, and the 2012 one. There's a bit of difference. I'm only going to highlight the differences because I was given 20 minutes only, and I'm sure we want to all finish off and go back to our families after this. So I'm only going to highlight what is new in the new guidelines. So what is new in the new guidelines is that there are a new set of levels of evidence. So these new sets of levels of evidence is much more stringent than the previous one. I shall show you the difference later on. So to be 1++, it means you have high quality meta-analysis, systematic reviews of randomized controlled trials, trials with very low risk of bias, and right at the other end would be just expert opinion without any trials to back them up. And so in between there are quite a lot of gradations, as you can see here. Then the grades of recommendation range from A, B, C, D. And then GPP means GP like yourselves. Good practice point. GPP stands for good practice points. So again, it's based on expert opinions, not based on any hard evidence. And to compare that with the 2004 set of guidelines, you can see it's much simpler here. The levels of evidence range from 1A, 1B, 2A, 2B, 3, and 4. And then A, B, C. The D is missing for 2004. So there's a bit of a difference here. So I think to make it to the new set of guidelines, grade A, 1++, you need to have meta-analytic studies, you need to have systematic reviews, low risk of bias and all that. It's very hard to get. It's just like a distinction kit, right? To make it right to the very top, you've got to get distinction all the way through. Now, screening for depression, this new guideline tells us that we need to screen for depression, and it recommends for general practitioners the PHQ, which stands for the Patient Health Questionnaire. 9 means maybe the 9th edition of it, and it's been used overseas, and also I understand that it has been used by some of you here, by general practitioners here. The GP member in our committee is very passionate about this, the use of PHQ. Now, use of antidepressants should be recommended as first-line treatment for moderate to severe. You know, paradoxically, the more severe the depression, the better that antidepressant medications are able to work. But even in mild depression, like subthreshold depression, that means you only have a few symptoms, then it can still work if it is persistent for more than 2 years or more. Low-grade depression, so antidepressant medications can also work. But for low-grade depression, you might want to go for psychotherapy, psychosocial approaches, not so much of antidepressants. So grade A and level 1+. Antidepressants are a treatment option in short-duration mild depression and should be considered in those with a history of moderate to severe. That means if there is a past history of moderate to severe and recurrent depression, and you know that depression can recur. So if you see a patient with mild, low-grade depression, but with a history of recurrent depression, and it has persisted for more than 2 to 3 months, then it's better to start the treatment, because you start the treatment early, you get him to recover faster. Choice. Now, what governs the choice is that if the patient has responded to a particular medication and has tolerated the medication with very minimal of side effects, that medication should be preferred. Conversely, if the patient has failed on a particular medication and found the side effects to be intolerable, that medication should be avoided. So don't use back the same medicine which the patient could not tolerate before. Start low and go slow, right? This is the slogan that we use. Once you start something, use a low dose and go very slowly. And then you monitor. What do you monitor for? 2 things you monitor for. Improvement in mental state and the emergence of side effects. So side effects are likely to emerge within the first 2 weeks of treatment anyway. So look out for it. Okay, our subsequent speaker, Ms. Koo, will tell you more about side effects later on. How often you monitor depends, okay, on the severity of the illness. If it's more severe, if there are suicidal tendencies, you want to monitor more closely, once a week, to not more than once a week, or once in 2 weeks if the patient's a bit more stable. Depends on whether the patient is prepared to come or not. The cooperation level of the patient is important, and whether there's available social support. If the patient has got family members that can take care of them, support them, then you're not so worried, and you may not insist that they come so frequently to see you. SSRIs stands for specific serotonin reuptake inhibitors. These are now the first-line treatments. Now, this is in contrast with the previous CPG, which mentions TCAs, tricyclic antidepressants. For example, amitriptyline, dotiapine, imipramine, tricyclics have now been relegated away from the first line. And the first line is now SSRIs. And they are very safe. They're well tolerated. They are safe. And for example, patients with cardiovascular diseases, tricyclics are very unsafe. There are 2 tricyclic antidepressants that are implicated in cardiac arrhythmias and even cardiac stoppage of heart in asystole, fibrillation, severely cardiotoxic. Tricyclic antidepressants, amitriptyline and dotiapine, are the first 2 culprits, with the highest morbidity due to cardiac side effects, the cardiac mortality. But SSRIs are completely safe in cardiac disease. Now, if you have a patient with a lot of medical problems and they are also taking concomitant medical drugs, you are worried about drug-drug interaction. Here, there are 2 SSRIs that are recommended, escitalopram and sertraline. These are very safe from drug-drug interaction, okay, especially cardiac side effects. So, as I mentioned earlier on, cardiotoxic side effects, you want to avoid the use of TCAs. And TCAs make a comeback again. And together with MAOIs, should the first-line treatments fail, we still fall back on TCAs. In fact, TCAs are still the drug in which other SSRIs are compared against, or newer antidepressants are compared against. They still form your comparator, TCAs. Now, there are other newer drugs, SNRIs, like venlafaxine. There's another drug, SNRI group, called duloxetine. Then there are NASA, mirtazapine. And then there's an NDRI, the bupropion. More recently, studies have shown that venlafaxine is even more effective than SSRIs. Venlafaxine has got serotonergic and noradrenergic reuptake inhibition property, so it's more effective than SSRIs.